Everybody. I am excited to be here. My name is Jeff Lancet. I am the chair of the Department of Malignant Hematology here at Moffitt Cancer Center. And today we're really excited to be um, uh, producing this webinar for everybody to really give you an inside look at some of the innovative therapeutic and diagnostic modalities being used in blood cancer research. And our department here at Moffitt, our malignant hematology department, is focused on really developing cutting edge therapies that treat a variety of different hematologic malignancies, and really a lot of research into the understanding the biology of these diseases. So I'm really excited to be able to kind of lead this webinar today, and we have some outstanding speakers that I hope will shed some light on some of the great work being done here at Moffitt for these blood cancers. Just a couple of housekeeping notes. Please keep in mind that the content of this webinar is not intended to be medical advice. So please consult your physician if you have any questions about your own medical care. Do not rely on this webinar for any immediate or urgent medical needs. And if you have a medical emergency, please call your physician or go to the nearest ER, dial 911, and never disregard professional medical advice or delay seeking care because of any information presented here within this webinar. So with that being said, I'd like to kind of give you an overview of the agenda today. So our first, we have topics on all three different disease categories: myeloma, myeloid leukemias, and lymphoid leukemias. And we have three experts in the field within the Department of Malignant Hematology who will be giving you overviews, and I will introduce each one of them separately before they begin their presentation. But I'm very pleased to start today with one of my colleagues here within the department, Dr. Kenneth Shain. Dr. Shain is a senior member in the Department of Malignant Hematology. He is also the co-director of the Pentecost Family Myeloma Research Program here at Moffitt, where he is working very diligently on really understanding the biology of myeloma and translating that into new therapeutic modalities, both for patients with aggressive myeloma or even patients with precursor conditions, pre-myeloma. And we've invited him here today to kind of give you an inside look at his laboratory and to discuss some of the work being done in the field of myeloma, especially as it relates to translational research within his laboratory. So Dr. Shain, welcome and thanks for being here.
Jeff and everybody, thank you very much for allowing me to participate this afternoon. So I hope everybody's enjoying this nice Florida weather because it's nice and warm outside. Not at all. I have a sweater on. This is not what we're supposed to be. It's supposed to be 70 and nice. But thanks everybody for joining today. And again, I get the privilege of co-directing our myeloma center, so our Pentecost Family Myeloma Center, which is a large group of individuals. I co-lead with both Rashid Baz and Melissa Alcina, a great group of clinicians, physicians, scientists, and support staff that do a lot of work. And really the whole crux of our program was based on personalized therapy. And how can we take patient material and patient data and patient journeys and translate it into real science and then translate that to the clinic. And so I felt like it was a really great place to start, was to have kind of our discussion, at least the first part of our discussion, in our Pentecost Family lab, where we take patient specimens, okay, and we can actually test them to different drugs, 31 different drugs simultaneously, create predictors of outcomes, so patient responses in real time, and give that information to clinicians, and to do a lot of research with this. And this is something that has evolved over time from therapies that were just done as standard of care, as well as today now CAR T therapies and bispecific antibody therapies. So again, it's an evolving thing, but you can see behind me, all these machines are running patient specimens almost nonstop to test how they're doing, what kind of drugs might be optimal for those patients. And that kind of just is the centerpiece or the crux or foundation of what we think is important for all the research that we do. And again, as Jeff brought up, is that really we're in a changing paradigm shift in myeloma therapy. So when I started 15 years ago, we started treating myeloma. We were at the point where maybe we could control disease and do a better job of improving outcomes. Okay, today, in the last decade, we've been making sure that we can actually have what's called functional curative intent therapy, where patients are getting really good therapies, lots of different therapies along the course of their disease, meaning multiple lines of therapy. But again, keeping people making memories, having great journeys along the way for long periods of time. And now more recently, we've evolved into a point where maybe the next step is we start maybe taking away some of these therapies and actually have people off therapy for long periods of time. So I would say kind of curative intent things. And again, these are all important for us to recognize because it takes a lot of individuals, both at this institution around the world, studying myeloma and identifying critical points that we need to address, okay, as well as developing new therapies. And so we kind of looked at it as we built our story around 4 major pillars of what we think are important things to look at. One is developing more knowledge about how people have myeloma, develop myeloma from a precursor state called MGUS. Believe it or not, everybody who had myeloma had something called MGUS before, which stands for monoclonal gammopathy of undetermined significance, kind of like a colon polyp is to colon cancer. But this is something that we all want to make sure we can figure out how does that develop, and are there ways we can stop MGUS from becoming myeloma, okay? Or are there ways we should start treating people who have high risk precursor states to then treat them earlier and have better outcomes? And these are all things that we're working on. We also know that treating newly diagnosed patients is critical and getting the best response we can, and maybe eventually getting curative intent therapy by overcoming drug resistance will be a critical part of this. So defining what makes patients low or high risk. We call them standard versus high risk patients. We also know that unfortunately today, and historically, all patients will relapse at some point, at least most patients will at some point, because there's a little bit of disease left over, and the disease develops ways around it. It figures out what drugs it's on, it can become resistant to that. So we need to figure out what those mechanisms of resistance are, okay, and what are the next things we can use to best target those therapies. Then, as I mentioned at the beginning, is that we now have this brand new aspect of therapy, which is harnessing your own immune system, whether it be through chimeric antigen receptor T cell therapy, meaning CAR T therapy. We actually take out your T cells, manipulate them to become targeted at your myeloma, and then grow them, make them better, and stronger, put them back in, you kill all kinds of myeloma cells, what we call T cell engagers or bispecific antibodies, where we give you therapy that actually brings your T cells to the myeloma cells to kill them directly. So 2 ways of harnessing your immune system that today are really reshaping how we talk about treatment of myeloma. And they are giving us responses and outcomes that we didn't think were possible before and are shifting that. So how do we integrate that into all of these therapies that we've talked about before? And so again, our kind of foundation is we want to use patient level data to do this. And that means phenotyping patients, which means what are they were sensitive to, their cells are sensitive to when we take them out of them on bone marrow biopsies. We figure out the genetics of the patient's disease, right? Can we get what's called the mutational status or changes in the DNA that cause myeloma and that are induced when you get therapy? We figure out what are the actual biological programs that are leading to resistance. We use RNA sequencing to do that. These are all things that we've said are the centerpiece of how we want to figure out ways around it. And we've been lucky enough to be able to build with your help, okay, with your donations of tissue, time, desire, and then things like that, as well as philanthropy to build rooms like this, because this is not science that everybody says is easy to say is going to have a great outcome. But because of you guys, we're able to build things like this to have all kinds of data and then get lots and lots of data for us. And so with those things, we can figure out what are the mechanisms of resistance, what makes someone high risk versus standard risk. These are all things that we're learning. So over the past several years, our group with others has really determined, one, we've reassessed and redefined how people, what MGUS is, what something called smoldering myeloma is versus myeloma, based on high level, highly granular genetic analysis, okay, using whole genome and whole exome sequencing. We redefine what newly diagnosed patients look like using, again, the same techniques, whole genome sequencing and whole exome sequencing. We've even applied machine learning to try to figure out how to better predict how those patients will respond to given therapies or even therapeutic ideas, okay? Now, more recently, we've turned this into how can we figure out what makes patients sensitive or resistant to CAR T therapy. And again, we've looked at the same thing, taking, again, your donated samples, okay, consented to donated samples for, and then sequence them, and patients who do well versus not, how can we figure out what those resistance mechanisms are to CAR T? And we're now partnering with several institutions across the nation, Memorial Sloan Kettering and University of Miami, to capture 500 patients of T-cell engager therapy, CAR T therapy through a grant to then allow us to look at how these things may be affecting it and what comes out on the other side. How does CAR T change the genome? How does CAR T induce mutations or what? So we can define what the next kinds of therapies are going to be. These are all things that we're working on every day, okay? And again, it's really important to note that there's a lot of researchers that are working on this. There's a lot of clinicians that are working on this, and this directly translates to the clinic. How can we better allocate patients and give them therapy? And I want to emphasize that, again, these projects are, I think, groundbreaking. They're unique, but they also take a lot of grassroots and ground roots kind of work. And they wouldn't be possible without places like the Pentecostal Myeloma Foundation, where we've had some philanthropic funds. The smoldering and the MGUS, the precursor disease state thing, we've had some great support from the Bolin Foundation, okay? These are folks that are helping us do things we couldn't do so otherwise, okay? And the Gould Foundation has also been a fantastic supporting enterprise for us as well. These are all things that, again, allow us to do research that is on the cutting edge and allows us to take our research to a whole nother level, right? This is what we can do. What can we do in the future? I think what's really, really interesting with all of this data is you've now donated tissue, you've donated your clinical course, i.e. your patient journey along the way with us. And now with what we call artificial intelligence and large language modeling, we're able to then pull all of this together. And the next step for us is to put all these pieces of information together and help predict who is going to do well, who's going to need what therapy. So actually bringing in a lot more data into different stories, okay? And so we have a AI initiative around predicting what's going to take someone from MGUS to smoldering to myeloma. An AI project, who's going to achieve great responses with certain therapies in a newly diagnosed setting. Kier Freeman, one of our great CAR T physicians here and VMT physicians, is working on how we can bring in radiomics as well as other aspects, pathology, to predict how CAR T therapy is going to outcome. Doris Hand, who's one of our great junior faculty as well, leads a consortium around the country, pulling in all the clinical data from 22 different centers around the country, trying to figure out what are the clinical factors that lead to good outcomes with CAR T or toxicities with CAR T. So there are a lot of initiatives that really are based on patient level data. And I'd like to think on some level that we've been helping to do this and helping to kind of be a nidus for how this works around the country. We are not the only place, but it's something that we find near and dear to our heart. And without our patients, without their time, without their generosity, both with their tissue and their time and their clinical data, as well as in some cases, philanthropic funding, we couldn't do all these things. And so I think overall, I come back to this. This is a room that was built on personalized therapy. The whole point of this room is to how can we help an individual get better outcomes? And I think as we grow our data and as we grow our influence, we're getting closer and closer to where we can actually make really personalized decisions about patients. I don't think we're quite there yet, but we're on the cusp of that. So I just wanted to say, thank you for giving me the opportunity to talk to you guys and kind of highlight what the work we've been doing for a long, long time now is and where I think we're moving to in the future, which is maybe today a disease that we've talked about as being one that's very challenging to cure, to having functional cures, long-term good outcomes requiring lots and lots of different lines of therapy as patients succeed and then fail therapy. So maybe the horizon is, and hopefully closer than we think, is really can we start changing this to a curative intent therapy for at least large groups of patients, meaning getting really good therapy and being off therapy for really long periods of time. So with that, that's kind of a summary of where we are, summary of what we think is the critical aspect of our endeavor, which is, again, personalized therapy, gathering data, patient level data. And this will also include outcomes. This will include how you feel about things. As AI becomes more and more involved, we can put more and more data into the equation. So again, just wanted to thank you. And again, thank you for the time and the effort and participating with us today. And I'm sure you'll hear some fantastic discussions from Eric and Javier as we go through. And happy to answer questions when we're all finished.
Yeah, Ken, great. Thank you so much for that presentation. Just really emphasizes the fact that personalized medicine for myeloma is not pie in the sky. It's here. And you guys have an incredible toolbox to work with right now to address each individual patient's situation through being able to test the sensitivity of cells, to look at using AI with large-scale data, personalized tissue banking approaches to understand each individual's myeloma individually. This is great stuff. So Dr. Shain will be available as will the rest of the speakers at the end of the seminar to answer questions. But moving along, I would like to next introduce Dr. Eric Padron. Dr. Padron is the scientific director of the Malignant Hematology Department, also a senior member and professor, and the Sykes Endowed Chair here at Moffitt Cancer Center. Eric is a physician scientist whose interest
Thanks,
is in
Jeff.
myeloid malignancy.
And thank you to
And just,
the
oh,
people
are you
on
there?
the call for your interest and your time. So what I'd like to talk to you about today is the idea that leukemia can be prevented, and that leukemia, even when diagnosed, if diagnosed early, can be stabilized to become something of a chronic disease. And that is really one of our major goals within our department, but also within my laboratory. So part of the reason why this is a possible and tractable goal is that we are learning within the last 10 years the natural history of leukemia. And that is that there is a very long period um, from the undiagnosed time point to the diagnosis in which patients are identified and in which patients their disease is watched with no intervention. That's the current standard of care. And the disease and how it moves is something that we're learning based on research here at Moffitt, but also around the country, which we collaborate with. And that is that there is a condition that we see where the genetic determinants of leukemia are present in people. And this is lots of people. I write here 20 million, but it's estimated it could be up to 50 million. If you're 70 years old on the call, there's a 1 in 10 chance that you have these genetic determinants. If you're 80 years old, there's a 3 or 4 out of 10 chance that you can have them. So lots of people have this. Some people with this then go on to get an asymptomatic disease. And then most people, unfortunately, then have a symptomatic disease, which can be life-threatening. And therapy is only given here. And we want to understand who are the people that are going to progress, why are they going to progress, and what can we do to prevent that? Next slide. So one of the central hypotheses of my laboratory is that one of those things that triggers this natural history, this progression, is inflammation. And inflammation is a very vague word, but we have specific definitions of what we mean by inflammation. And in fact, acute inflammatory events, things like infections, surgeries, exacerbations of autoimmune diseases, all constitute acute inflammatory events that change the environment within which the leukemia is growing towards a more favorable environment for the leukemia. And so, what we want to understand is it true that inflammation is a trigger? Often I have patients that say, you know what? I did have a hip replacement, and then a few weeks later, they found evidence of leukemia in my blood. Or I had this really bad pneumonia and I was in the hospital, and we found this. So we hear these things, but no one has really looked at this in a rigorous and comprehensive manner. And so to answer this, one of the big studies that we have here in a chronic form of leukemia called CMML is something we call the INTERCEPT study. And what we do is we watch patients who are in that asymptomatic stage, and we call them every month and ask them, have they had any acute inflammatory events? And then see if their disease is progressing over time. So there's no intervention yet, but the idea is if we can figure what it is and what are the secreted and inflammatory factors that are responsible for this, we can interrupt it. Next slide. And so we've actually had this study for a couple years running now. And we presented this at our annual meeting just actually just about a month and a half ago in Orlando. And this is a study that's funded by the National Cancer Institute for 5 years, and something we really want to expand globally. And there's a lot of interest from investigators around the world after seeing this data we presented a month and a half ago. And what we show is that we were able to very quickly enroll 110 patients with this rare chronic leukemia who were asymptomatic. This is how old they were and their ethnicity. And then we were able to follow them. So on average, we were able to follow them for 475 days. About 80% had one of these acute inflammatory events, and 38% of patients progressed within that 475-day window. And this is something that is prospective, meaning we're looking at it, we're not going backwards, we're not doing chart reviews, we're literally monitoring patients monthly, which is thought to be the most rigorous way of doing this. And our initial results confirm our hypothesis and what we see in the clinic, and that is the more acute inflammatory events you get, the more likely your disease is going to progress. So we're just starting to learn now with these types of studies that inflammation plays a very large role in pointing the natural history of these leukemias in an unfavorable way. Next slide, please. So it's not only that we are just calling patients, we're using their specimens, the blood that would have otherwise been thrown away, or the bone marrow specimen that would otherwise have been thrown away because it was excess and not needed for the clinical question at hand. We use those samples and use state-of-the-art technology called single cell sequencing. And this is state of the art because rather than sequencing a bunch of cells ground up in one bulk mass, we're now able to say not only what the leukemia genetics look like, but what do they look like at the individual single cell of a patient. And we typically sequence about 4,000 to 5,000 cells per single patient. So these data sets are massive. And what we're starting to see is that there are changes in the bone marrow that we can only appreciate with this single cell sequencing technology that really change when patients progress. So there are cells, these are cells here on the y-axis, and these are their fractions in the time point before they progress versus the time point when they progress. And these in blue are increasing, these in red are decreasing. You can see that there's this massive expansion of these cells that we call GMPs that are really inflammatory cells. Under normal conditions, when we have a big infection or surgery, these are supposed to increase, but we're understanding now that leukemias are essentially hijacking these processes that are that are normal and that help us fight infections. They're hijacking them for their benefit, and rather than going up and then coming back down, these GMPs are going up and staying up. And we really think that these cells are really one of the key players as to why inflammation triggers progression and ultimately why patients progress. So this is just a very quick snapshot. We're doing so many other biologic experiments, and we have a variety of cohorts that we're looking at. But science at Moffitt here, we're focusing on preventing leukemia from ever happening, or if it does happen forever from ever causing symptoms, so that it's a chronic disease. And we're doing that because that is the strategy in cancer in general that has been the most fruitful. Preventing it from ever happening is much better than having to treat something, and even worse, treat something that's causing problems. We're just beginning to understand how inflammation shapes and promotes disease progression. And we're not looking at ground up cells anymore. We're looking at things at single cell resolution. That allows us to explore the heterogeneity of the disease, to look with precision that we didn't have before, at different cell types that are increasing and decreasing, to ultimately catch this leukemia early and mitigate the disease progression early. And then the last thing I put here is at your support makes all the difference. But I kind of want to put some context into this. So, our biggest funding source is the National Institutes of Health. And as you may have heard, there's been dramatic decreases in the budget, 30+% budget cut, which is made now the pay line. So, what we call the benchmark for getting funded, the lowest it has ever been, which is the fourth percentile. So as we're writing these grants, and I am literally writing one right now for this topic, we're writing them. We're putting out as many of these as we can. There's only a 4% chance that these get funded. So your support now more than ever makes a huge difference in how much of this research we can actually do. So thank you very much.
Thank you so much, Eric. That was an outstanding talk, and it's becoming clear that leukemias, especially myeloid leukemias, they're not diseases that pop up overnight, but they're more longitudinal diseases that evolve and progress over a longer period of time, and that this creates opportunities to develop interventions at different times of the disease, depending on how it's behaving at that time. So Dr. Padron's work is really instrumental in kind of identifying the appropriate therapy for individual patients along that spectrum of disease, from very early precursor states where inflammation may be the bigger problem to later stages of the disease where different mutations may be the problem. I'm really pleased next to be able to introduce another outstanding member of our department here. His name is Dr. Javier Pinilla, and he's a physician scientist. He's a senior member, and he is the lymphoma section chief here at Moffitt. So as most of you are aware, immunotherapies have become a critical component of treatment for many, if not most, lymphoid cancers. And in CLL, chronic lymphocytic leukemia, which is the most common type of leukemia in adults, there have been great strides that have been made in targeted therapies. But now we're learning that immunotherapies are also playing an increasingly important role in this disease as well. So I'm pleased to introduce Dr. Pinilla to talk about some of the developments in successful immunotherapy options in CLL. So thank you, Javier.
Thank you, Jeff. After a great presentation of my colleagues, Eric and Kane, I'm gonna really talk to you about some condition that may be familiar with you because it's relatively common in older population in the United States. It's chronic lymphocytic leukemia that is no more or less than a chronic lymphoproliferative syndrome, but also we also call a low-grade lymphoma because at the end we're talking about B-cell malignancies. Next slide. And I'm going to introduce pretty much this condition. It's an incurable condition and is very common, as Dr. Lancet said, in adults patients. And the median age is 70-year-old, and they have this expansion of these very specific cells that can really be marked with technologies like a flow cytometry, and they pretty much give us the diagnosis. The presentation is very different from patient to patient. Some patients may really be seen by the doctor PCP because increase of lymphocytes, but other patients can present with swelling lymph nodes or even some other really B-cell symptoms of fever, of weight loss, right? I think overall we now, the CLL is quite frequent. You see here around 20,000 cases. We need to understand that in the community that we are seeing, the early stage CLL we call monoclonal B-cell lymphocytosis is as often as 20% of the population over 70. What I mean that it's not like these people over 70 have the disease, but they may have some of the cells that may one day raise to this condition, and of course, and somewhat maybe contribute to some immunodeficiencies that have been seen, for example, a lack of be successfully vaccinated or really increase infection and even increase secondary cancer. So the next slide really put together the key message here is the T cell. The T cell is a form of cells that we have in our immune system that they will protect us against many things, right? We are talking about this disease is come from the B cells. So in the best case scenario, these T cells can try to attack and really get rid of the cancer. In this case, what is happening, and based on the dysregulation of the immune system by the growth of these B cells in the lymph node, in the bone marrow, in the blood, these cells start to really be not competent. And that's the reason, and I put this slide, and you can go with the next slide, please, is that the adoptive therapy is quite successful in the world of lymphomas, where we really have, sorry, the previous one, please, when we really have a very successful in the world of diffuse large B-cell lymphoma, aggressive lymphomas. In this specific condition, they are not being as successful. And as we reach a 40-50% complete responses in lymphomas in CLL, we really get trouble to get to the 20%. And the reason is because the tremendous dysfunction of these T cells in patient, reason by why immunotherapy strategies in this kind of condition are not being successful. And obviously is the key kind of a way to really not improve this condition in terms of eradicate the disease, rather to improve immune system in the long run. So the next slide really brings you the fact that we start to really reproduce this problem doing an we call immunocompetent mouse model. And I'm not going to bore you, but pretty much we have a normal mouse that we really injected with these leukemic cells, and we see how this T cell starts to really be affected. And the next slide, you will see that the hypothesis that we have been generating and for which we have been working for quite a while is that this specific type of T cells called CD8 cells, or CD8 killers, in this mouse model, they really have a very specific problems that comes from the metabolic and specifically mitochondrial abnormalities. You may know or not that any cells in our body require energy, and they really need to grow and stop. And all these energies pretty much come from these mitochondria, these organelles inside of the cytoplasm of the cells. So our hypothesis is that these mitochondrial organelles in these T cells are completely dysfunctional, and we are being able to correlate these metabolic abnormalities by very sophisticated assays with leukemia progression and, more important, an exhaustion, as you see here in this picture of the CD8 T cells, that they make them unable to respond against the leukemia overall. The next slide, you see that this is the key message of why we really try to understand and how we're going to try to really overcome. And this is what we also work and published recently, how to really encounter specific pathways inside the T cells that will allow to reprogram to and allow this T cell to be rescued and start to really work more efficiently. We call the PI3K pathway, and we have medication that really can block this pathway and hopefully can, in the real setting, improve adoptive cell therapy. In the next slide, obviously, we start doing this. In the next slide, with the fact that keep going, CLL cells, as you see, they have multiple defects, as we described, in the mitochondria, in the surface molecules that make them less efficient, and many other abnormalities in the ER stress and endoplasmic reticulum, that through this treatment in vitro and other really much sophisticated ways to do that, we may able to reprogram and make cells much more efficient to really use as adoptive therapy, but also hopefully in the future to improve the immune system of these patients. So in the next slide, we see an example of this, and you can go through that, how blocking in vitro, while we manufacture for the mouse this CAR-T, you may have heard about CAR-T technologies, is the technology where you really get cells out of the patients and transduce them with a specific gene that will recognize, in this case, the target, in this case, the leukemic cell. We know that we do this in CLL patient. This is not very successful, as I showed you before, but if we really manipulate these T cells in the growth in vitro, we allow a very robust expansion is what we want, expansion of this CAR-T inside the animal models. And obviously, this translates survival, and we have even more recent data that suggests that animals can really have long-term cure. So the next slide, we will show a more sophisticated way, but I just want to reintroduce another topic briefly, is the fact that it's not only these T cells are dysfunctional, the microenvironment, a very, very important aspect of the biology of this disease, is also really defective. And you see here, you see all these molecules that also been discussed by Dr. Padron, this inflammasome system, these inflammatory molecules that really make this tumor microenvironment very bad for the T cell to really do that. And we recently have also experienced to manipulate that through specific drugs who block a very important molecule called S109 to really overcome the suppressive tumor microenvironment. The next slide will show you briefly a couple of examples that we also translate this in the animal models, and we're able to treat this animal with this medication and successfully control the disease. But the next slide also represent the fact that we can really do in the xenograft models, doing like using human CLL samples at one more time, and really recapitulating what Dr. Shain said. We are really able, thanks to your help, to really get the samples for patients who donate blood, and really being able to show once again that these drugs can blocking this pathway can able to eliminate, or at least to dramatically reduce that. And I don't show you here because there will be too much. Also reprogram certain population of myeloid cells, as mentioned also by Dr. Padron, that will be really deleterious for the immune response in patients with CLL. The bottom line is that through these kind of dual projects, really getting directly to manipulating T cells as well the tumor microenvironment, we really hope that we can translate this, and we are already have some preliminary data that's going to be used in humans to really improve the outcomes of these new technologies, and many more that coming in the future, like a bispecific antibody, as also Dr. Shain has described in myeloma. Just to really finish this presentation, in the next slide, I will want to really, and I'm sorry, this is just before that, I thought I didn't have this slide, but just to show you that this manipulation improve outcomes in that same CAR-T model that I showed you in the beginning. So we can manipulate the T cells from one side, and we can manipulate the tumor microenvironment, and I think both together will be optimal to achieve these better outcomes. All these things, please, the next slide, won't be possible through multiple, partners, collaborators here in our institution, in outside institution, and obviously the philanthropic support by many people who are involved in our research for years, Mr. Ferrioli, the Brown Foundation, and Lisa Hall, that also has been crucial, as Dr. Eric Padron has mentioned, to maintain the research funding in these very important, projects that will really improve the lives of patients with B-cell malignancies. Thank you very much. We'll be more than glad to answer any question.
Thank you so much, Javier. Wonderful presentation, and I think just really illustrates that we're just sort of seeing the tip of the iceberg when it comes to immunotherapy options for CLL, and that there is an incredible amount to learn about the biology of this disease, but some incredible options that we have at our disposal now through CAR-T and through bispecific antibodies that can really, potentially be very helpful in these diseases. So what I'd like to do next is basically to introduce to you Tyler Wilson. And Tyler is one of the senior foundation officers here at Moffitt, who works intricately with the Department of Malignant Hematology and several of the faculty and staff here, and has really been critical towards developing philanthropic relationships that have supported a tremendous amount of blood cancer research here at Moffitt, including amongst the individuals you've heard from today already. So just wanted to have Tyler say a few words and thank him for all you've done for our department and for our patients.
Oh, thank you, Dr. Lancet. I really appreciate the opportunity to be here this afternoon, and thankful for everybody that joined us today. And I think, Dr. Pinilla's presentation in the last slide and showing the number of collaborators that he has inside of Moffitt as well as outside of Moffitt. I think really details how complex research can be and the number of different people involved and why philanthropy makes such an impact across the board here at Moffitt, whether it's with lymphoma or multiple myeloma or leukemia space. Those collaborations are constantly happening within Moffitt, and the opportunity to have available funding through philanthropy really helps allow those collaborations to happen and for new ideas to be moved forward. And as Dr. Padron mentioned, to take some of those ideas and move them towards larger federal funding, or then to take those ideas and move them towards clinical opportunities and clinical applications, like Dr. Shain was discussing with some of the AI initiatives and what they're doing with the Emma platform within multiple myeloma. And so, each of the projects that were discussed today were impacted by philanthropy, and we're so grateful for everybody that's made an impact here at Moffitt through their support. If you'd like to learn more about making a gift, my personal cell phone is listed on the screen as well as my email. Feel free to give me a call or shoot me a text. Find time to meet with me. Would be more than happy to discuss your philanthropic interests when the time is right for you. At Moffitt, we try to make it as easy as possible to designate a gift. You can designate your gift towards malignant hematology to support all of the blood cancer research at Moffitt, or you can narrow it down as well to support specifically leukemia or lymphoma or multiple myeloma, and would be happy at any time to discuss any of those interests that you might have when the time is right for you. So thank you again. And with that, I'll transition it back to Dr. Lancet to start the Q&A.
Thank you, Tyler. And thank you for the great work you've done on behalf of our patients. And as Dr. Padron had alluded to before, philanthropic gifts they've always been critically important to our mission, but they're even more important in the era of reduced funding through other sources. So really appreciate, Tyler, your ability to help us kind of develop partnerships with our patient and donor populations. The next part of this seminar, we're going to finish up in the next 15 or 20 minutes with a Q&A session. And what we're going to do is, I think you've all seen that there's a Q&A box that you can enter questions in, and we will answer these questions to the best of our ability in a live fashion. For those questions that we can't get to live, I've been told that we can answer them indirectly or directly through written responses that will then be emailed back to the person that asked the question. So if we don't get to your question live, please stay patient. We will try to address them all in written form in response after the webinar is over. So why don't we go ahead and get started? We have our panelists here. I'll be kind of proposing the questions to the panelists that have showed up in the box. So one of the first questions was addressed towards Dr. Shain. How do you see CAR T therapy replacing autologous transplant as the standard of care in myeloma in the future, and whether donor T cells off the shelf could also be options for these patients?
So fantastic question about CAR T and myeloma. The answer is we don't know yet, right? Because those studies are ongoing. In fact, Omar Castaneda, who's one of our fantastic CAR T physicians here, transplant physicians here, just led a study called CARTITUDE-6, which is actually testing that exact question. If you get induction therapy for newly diagnosed patients, do you get randomized to transplant versus cilta-cel or Carvykti, and how do outcomes change? And just finished enrolling across the world. So we'll have better answers like on that in the future. And there's also 2 studies led by Dr. Alcina here looking at that as well for high-risk patients, looking at different CAR T constructs. But long answer short is we all hope that CAR T really changes the world, and do T cell engagers, because the early data suggests that they're getting us responses even in that setting that we've never thought of before, and will hopefully make transplant thing of the past. But we've also been trying to get rid of transplant for 30 years, and we haven't done so. And transplant, again, is high dose therapy, so that's the part no one likes. So my guess is there'll still be a place for it for certain populations, et cetera, but that data is being gathered and collected now, and hopefully soon we'll have a better answer. And do I think it's going to? Yes. The problem is I don't know the answer today. In fact, I would put money on it, but I don't know that for a fact.
Thank you, Ken. A question, I think, directed towards Dr. Padron on the INTERCEPT study. Will that be likely to be expanded to multiple sites in the future?
Yeah, in fact, it is already. So we've enrolled 110 patients at Moffitt, but we've also enrolled 50 patients at Mayo Clinic in Rochester. So it's open at two sites. But as Tyler will attest to, we're actually trying to make a global consortium around this based on the initial results, and philanthropy is going to be a key a component of how we get this done. There are at least 7 centers interested and are willing to either join either with or without funding, and they include the largest centers in the country: MD Anderson, um, University of Utah, Vanderbilt, and many others. So that's the hope. But again, philanthropy is one of the key ways that we can actually make it happen.
Thank you, Eric. A question maybe I'll direct to Dr. Pinilla, and paraphrase it just a little bit, but it was a question about the potential role of radiation treatment in lymphoma in light of sort of the overwhelming development of systemic therapies, including immunotherapies. I guess the question is, do we still see a role for localized therapy for lymphoma as opposed to kind of moving away from that?
Yeah, that's a good question, but also rather complicated because depends pretty much of the type of lymphoma that we are dealing for, right? But definitely in low-grade lymphoma, still radiation may have a role in a very early stages, depending of the location. Sometimes we need to really take into consideration. But it's true that radiation over the last years, over the years, it's become more and more safe and can be delivered. However, I will say that it's not really a very useful, or at least very common, really use technology, because most of the patient is not present in the early stage. They have already what we call more advanced disease. But definitely in the patient who accidentally many times diagnosed with this, with a certain type of lymphomas, it may really have a role. Another role that we been more recently kind of experience or working on is in patients who really have a very good response, but there's still some area that they are not fully resolved, where consolidation with radiation may really help to maintain responses. And even we use the radiation as a bridge to this new technology called CAR-T that we've been discussed here, just to really avoid other chemotherapies and really maybe, and it's one of the hypotheses, really induce an immune response through the destruction of the cells by radiation that can really be beneficial when the CAR-T are later introduced. So that will be a very, very wide overview of rather complicated topic in different lymphomas.
Question I'll direct to Dr. Padron relates to the question of whether certain genetic alterations or mutations can render certain treatments ineffective, including bone marrow transplant, and whether, as clinical investigators and scientists, that we can address these types of genetic alterations in our treatment plans to help cure more patients.
Yeah, it's a great question. And the most fundamental molecular changes that we try to understand in not only leukemia, but any cancer are the genetic mutations. So there's been decades of research that can answer this question. I'll just focus on one of the mutations, which is a mutation in a gene called P53. And we know that these genetic mutations not only make patients more resistant to therapies that we have, but also make them more resistant to bone marrow transplant and relapse after bone marrow transplant. One of the things that I think is a huge asset in at here at Moffitt is we actually have the world expert in P53 mutations. His name is David Solomon, and he's done a lot of work in this area. And what he's already starting to show is if you can pick the right treatment to get the mutation down, so from, let's say, 50% to 15% or 10, or even not be there at all. If you do nothing, it'll come back. But if at that moment you can get to a transplant, that gives patients the best chance of long-term survival, even with the worst of the worst genetic changes. So what we're trying to do is track these over time, come up with the evidence to say that, if we target it with this therapy, if we knock it down this much, then transplant, which is what we would hope to be the definitive curative therapy, has a better chance of working. So there is a lot of research here at Moffitt to answer questions just like this. And we have the experts and we have the patients, and with your help, we'll have the resources too. Thank you.
Thank you, Eric. Dr. Shain, a question for you about the role of genome testing in myeloma being applicable to all different phases of the disease, or really more in just the more aggressive, full-blown disease status?
No, that's a fantastic question. And essentially what we've learned, not to get too granular, but essentially is we did whole genome, whole exome sequencing on 2,000 patients from across multiple institutions across the world. And we identified kind of all the 180 things that can happen to the genome that are linked to myeloma. And we helped better kind of put people in categories of risk. And then we actually then took the largest cohort of patients with precursor states and applied that to them. So the same things we can find in both places. It's the amount of that and how much of those things actually are there in myeloma that are in precursor states that allow us to kind of better parse the risk of progression to myeloma. Again, these are early studies. These are published in the last couple of years, and we're now looking at larger cohorts to try to validate these things. But essentially, it is the genomic features of myeloma. Now, everybody's a little different, has their own features, so the more people we have, the better off we'll be. But those features can help us, again, better categorize people into what we hope how their outcomes will become, but also what therapies should they be getting, what different aspects of therapy should they be getting. For precursor states, we can watch versus maybe this is actually a new definition of myeloma. If you have these genetic events, you aren't smoldering or a precursor state, you actually have myeloma need therapy as such. Those are things that are going to evolve in the next couple of years, but really are critical in helping redefine this. And I would say it's even happening. We're doing it with T-cell engagers. We're doing it with CAR T as well. What are the genetic features that are associated with good or bad outcomes? We can balance who should get CAR T, which is outstanding, but if we know it's not going to work very well or has lots of toxicity, it's probably not something you want to undergo. So those are all things we're trying to use these genetic fingerprints for, to figure out what's going on and how to better allocate therapy as we go, both precursor, newly diagnosed, and even in relapse and refractory disease.
Thank you, Ken. I see a great question that I'll answer myself here. It's in regards to whether funds can be donated to malignant hematology nursing research to support our nurse practitioners and APPs who want to collaborate on research. And the answer is absolutely yes. In fact, that's one component of our department that we're trying to build out more thoroughly, is to focus on patient-reported outcomes research. We have a current nurse practitioner who's also a PhD, who is one of our nurse scientists here, and her name is Sarah Tinsley, and she's working on patient-reported outcomes following different types of therapy for acute myeloid leukemia in older patients. And we have a variety of other projects being initiated by Sarah and other colleagues in the outcomes, patient-reported outcomes arena. So we absolutely support that and welcome donations and funding that go to that very important component of research, which is quite different from what's being done in the laboratory, but critically important for our patients. So thank you very much for that question, and happy to follow up on that as well. Question for Dr. Pinilla. Is there evidence to suggest that a patient with CLL in more of an intermediate risk profile who's been on successful therapy might benefit from future therapies, perhaps with immunotherapies, by virtue of having more successfully treated disease initially? I think the question might be, can such a patient benefit from immunotherapy down the road if they've gotten successful targeted therapy to begin with?
Yeah, well, so it's a rather complex question because it depends on what type of therapy patients are really going. But if overall, people may refer to this already popular because we have been using for more than 10 years, treatment until progression, where people of patients in this case takes a pill and we don't stop the pill if it is not toxicity or progression, right? And there is a lot of really interest to really see some of these patients. And I have patients in my practice who really come and say, Doctor, I don't want to have this pill for life because, I'm tired, I have issues with insurance, so even I have certain side effects that they are not really, that don't let me enjoy my life fully, right? And in these cases, yes, we can add other types of therapies that can be able to eliminate further amount of CLL cells and allow to discontinue. However, it depends of the type of CLL. It's unclear that this kind of treatments it will cure, and we know that the disease will come back. But sometimes patients may enjoy period free of medication that can go from 3, 4, 5, or even more years, where patients can really have a normal life, and then when the disease come back, they may really return to the same medication of really new medication that may have come up in the meantime. So in terms of the immunotherapy, is something that we are discussing. If immunotherapy is something that can we do as a consolidation from these new strategies, something that is very much interest. Our institution and our department are really also very involved in bispecific antibodies. Even in the front line, we have a new concept trying to really not only eradicate the disease, but as mentioned, to really try to remodel the immune system. It's something that it may be coming in the future too.
Thank you, Javier. Question for Dr. Padron, I think that reflects some of the discussion about the role of inflammation in leukemia disease evolution. I think the question pertains to whether there are any sort of home-based treatments that you might consider to reduce inflammation that could have an effect on disease progression, such as diet or other daily habits that we might be able to kind of entertain as potentially useful in reducing inflammation in patients that are maybe at higher risk for developing leukemia.
Yeah, I mean, I think the general principle of having a healthy lifestyle um, helps as a general rule for a lot of reasons. Number one, some of these treatments are tough on your body, so being at an optimal state is, really an advantage. To be a bone marrow transplant candidate, you have to be strong enough to do it. Um, and to avoid certain diseases that are themselves nituses for inflammation, like cardiovascular disease and diabetes and things that we want to prevent anyway, are a good idea because it's not just the acute inflammation, but the chronic inflammation too. I would say that, to find leukemia specific inflammatory changes, I would say the research is ongoing. It's what my laboratory is focusing on. We want to find the specific aspects of inflammation that can be mitigated and targeted. And what I will say as a word of caution is just be a little bit wary about, supplements or over the counter therapies that promise to quote unquote decreased inflammation because it's a very vague term. And, I just encourage you to talk to your leukemia doctor or primary care doctor about it before you start something like that. There is right now no leukemia specific anti-inflammatory available, but my hope is that next year or the year after that, when we meet again, I'll be able to say there is.
And I think thank you. We have time for one last question, um, and then we'll certainly try to address all the other questions offline. Probably a question maybe that I can ask both Dr. Shain and Dr. Pinilla to answer is how do bispecific antibody therapies fit into the treatment armamentarium and support CAR T therapy in both myeloma and lymphoma? So obviously that's a hot area of research. Maybe you can comment on the role of bispecifics as they pertain to these diseases and how they fit in with CAR T.
I mean, Javier, I don't know if I'll just, since I started talking first, I'll go first, is I can't emphasize enough that CAR T and bispecific antibodies are changing the face of myeloma today. CAR T has so essentially the difference is access, right? CAR T, you have to be at a place like Moffitt, you have to get here to get CAR T. It's not Moffitt's not the only place, but we are one of the few places in Florida that do it. Bispecific antibodies still take some expertise, and we are one of the major centers, but our community oncologists are picking up and doing more and more. So these are things where access is critical. And so getting one of these therapies as part of your therapy is critical either way. If equal access is being granted today, we think of CAR T first because it gives you the idea of getting a therapy, having disease disappear for long, long periods of time without any subsequent therapy thereafter. We also know today, if the CAR T and bispecifics are targeting the same thing, we know that T cell engagers or bispecifics before will kind of negate the efficacy of CAR T. So you've lost a part of your therapy, right, or your therapy. So all access being equal, we want to do CAR T first, bispecific second, but you have to have access. But bispecifics are almost as good as CAR T. They're just longer term therapy. And as you learn how to use them better, and in different places, they may be better for certain individuals. For instance, we know from early data of looking at bispecifics after induction therapy of newly diagnosed patients, everybody who gets them after 6 cycles is MRD negative, which means we can't measure disease down to 1 in a million cells in your marrow. So maybe that's the ideal setting for bispecifics. They may be even better than CAR T in that scenario, where there's less toxicity for short periods of time. So these are all things that we're figuring out. So I always make sure that it's not and or, right? It's and. You're going to use these things across time, and you're going to develop them in different phases, and it's important that you discuss with your physicians what the options are. And again, it's always a challenge to get to places like Moffitt, but when you have therapies that are this much better than anything else we can offer before, you need to have access to these therapies. So I would do all you can to educate your friends, your other, myeloma patients or any patient who has a disease that's treated by CAR T or bispecifics to get to someone who can give it and educate you about it so you can make the right decision for you. It takes a little bit more work, but again, these are that much better than everything else. It's like normal therapy, CAR T, bispecifics. I mean, that's the difference when you think about it. So getting and educating is a really important thing. And we keep working hard to educate our community and bringing these bispecifics out to the community, teach them how to give it better, faster, and easier for you guys. So again, I don't know if it's definitely not an or, it's an and. So we got to think about how they get integrated together. I'll stop there. Javier?
Yeah, briefly to agree with Ken, in the world of lymphomas, obviously both the strategies are approved, and I think we're still learning how to really combine, and we're still unclear which one it have to be first. I also agree with Ken, depends of the access. For sure, we have long-term data with CAR T. We start to really have this data with bispecific, and we're still really looking at the question is bispecific is better before the CAR T or is really better post-CAR T? All these questions, I think, is going to be clarified in the next year. I think the more important message is these two technologies are extremely efficacious in really, saving patients from relapses and prolong really, really good survival and allow patients keep going on. So I will stop there.
Thank you, Javier. And then I wanted just to kind of get your input. I know we're running a little bit over, but it's a really interesting question about the potential role for genomic analyses or sequencing, not just in patients who have cancer, but in patients perhaps well before they ever develop cancer, or maybe as a screening technique. I'm just wondering if we can get some thoughts on how you would envision the role of sort of genomic sequencing as a screening approach in large populations of patients, not just necessarily cancer patients or patients that we know are in the early stages of cancer. Eric, maybe you can, if you're still on the line, you could comment on that. If not, Javier or Ken.
I mean, if Eric's on mute, yeah, I know he had his heater guy coming, so who knows? I think it's a more challenging question, right? I think you heard me today talk about how we're trying to use genomic screening in the context of defining risk in a cancer, defining risk of progressing to a frank cancer from a pre-malignant state. I think it's important that we continue to learn and grow databases and learn what these changes may be that are in our genome, not the ones that predispose us to cancer. I think those are critical things for us to figure out. But I think it's a little bigger lift. I know there are groups out there and there are assays out there that allow us to do that. I had a patient come in and they were very excited that their test identified that they had myeloma ahead of time, but really it was just they already had myeloma. But these are things that they're in the future, they're there. So how we start using them is based on getting data and really what does it mean, especially in diseases that aren't super common. And again, you're talking about the three people today, four if you include Jeff, right, who studied diseases that are relatively rare. We know lots and lots about them. So I think it'll be really important to figure out how this may apply to lots of different diseases.
Yeah, I'll just jump in and kind of follow up. I think it's also going to be important. I mean, I think the future of screening for genomic alterations is going to depend on potentially viable interventions that we need to study before we introduce mass screening, and also justification to payers for doing this. If we can't intervene in a meaningful way, either with novel therapeutics or immunotherapies, or even develop a very strong prognostic model, then we have an expense that doesn't necessarily create a return on investment. And thinking with your medical economics hat on, that could be a challenge when it comes to screening general people in the population outside of very high-risk patients or those that have cancer at some stage.
I agree 100%.
Yeah, I think with that we'll close here. I want to thank all of our expert physician science panelists for their great discussions and addressing these very insightful questions. I'd like to thank our audience for joining us today, and hopefully everybody learned something about the field and also learned a little bit about our program here at Moffitt and the work that we're doing, and hope that leads to more interactions and relationships moving forward. I'd like to thank Tyler and Lane Thompson and Stacy Price for putting this program together. I think this is the fourth or fifth year we've done this, and it seems to be growing every year in both numbers of participants and interest level and follow-up discussions that result from this webinar. So thank you all for participating. And like I said, we will try to answer questions offline that we couldn't get to live. So keep your eyes open for return emails about some of these questions. And again, thank you for everybody's interest and participation, and look forward to our ability to continue running this webinar once a year or more if we need to. Thanks.
Take care. Bye-bye.